Hello, test. Thank you. So, are you able to hear me and see me? Give me a thumbs up if you are able to hear me and see me. Such a pleasure to be back to all of you with the Predictor series. Okay, so let us have a good discussion on radiology today. And I also want you to, I wanted to share with you the news that we have already seen that NEETPG will happen in single set, and I am always a big fan of single set paper because I always believe that is the only way to ensure maximum transparency. Because whenever we go for multi-set papers, they include a lot of statistics in the picture, which increase the confusions and reduce the transparency. So, I have multiple times, always written on Twitter also that, it should be a single set. So, the exam is now going to be in a single shift, and I think the court has directed the national board to come up with the formula. So, I'm sure by Monday we should all be wiser about the dates, and maybe they might also come up with the same date only. It is possible to do the exam in same date only, but let us see what they decide on Monday. Okay. Okay, and the good thing is when it is a single set, if it is hard, it is for everyone, and even if it is not hard, it is same for everyone. So it is a good decision by Supreme Court to take cognizance of this fact that it creates confusion. And every year we see that after the paper, the children will come to me and say, "Sir, मुझे लग रहा है मेरा मुश्किल था या ये morning वाला easy था," which is not fair. So I think that is a good decision by Supreme Court, and I think they should stay on this decision consistently in future also. So it should be a single set. And I know, some people have the concern about postponement or preponement. I think the decision will go from the court to the national board, and then national board will come back with the idea that how fast they can adapt to the new judgment, and how fast they can add more centers. Okay, so as of now, my goal will be, let us revise radiology, and let's not think over भाई क्या होगा क्या नहीं होगा. Probably it's for good, because once it is a single set, it becomes very like the traditional paper. In India, we are all used to a traditional set of paper that भाई जो मेरे क्वेश्चन आ रहे हैं वही सबके आ रहे हैं. So that is what the Supreme Court has decided, and let us now use the opportunity that we have to revise radiology. Okay, first question. Let's see how many of you are going to answer this question and tell me, this patient came to emergency with loss of consciousness, NCCT is shown to you along with a CT angiogram. You need to tell me what is the image showing us and what is your idea. This is the question from last year's NEETPG paper. NEETPG paper classically is like this: a short stem clinical vignette. It is not like USMLE, don't get confused. USMLE के पेपर के अंदर the questions are much longer. In NEETPG, the pattern will be a short stem clinical vignette with a image. Usually the image will be a clinical image. For example, this is a history and there is an image. So I want all of you, and this is, if you have attended my PYQ kebab session, you will be able to do it very fast. There is blood in the cisterns. There is blood in the sulcal spaces. Okay, so if you see blood in the sulcal spaces, blood in the cisterns, this is called as subarachnoid hemorrhage. Why would you have subarachnoid hemorrhage? Because in this patient on a CT angiogram, we are able to see a berry aneurysm. So probably it's a aneurysmal rupture. So what is your answer? You can see the star shaped blood in the cistern. The answer is subarachnoid hemorrhage. Now the questions that I have for you are, when will you suspect AV malformation? Anyone? What should be given in the question, in the choices, which will make you think about AV malformation? Anyone? The answer will be, if you have a lobar hematoma in a child, if you have a brain hemorrhage in a location which you cannot explain by hypertension, a lobar hematoma in a child, you will think of AV malformation. So what is a AV malformation? AV malformation, look out for these words: arterial feeder, nidus, draining vein. Are you clear? Okay. So first question for me, and I wanted to all of you to answer this question for me is, okay beta, tell me, if you have a lobar hematoma in an elderly patient, if you have a lobar hematoma in an elderly patient, what will you suspect? Anyone? Elderly patient, if you have a lobar hematoma, you will suspect amyloid angiopathy, cerebral amyloid angiopathy. Okay. Another question on the same lines that they can ask you in your NEETPG is, how will you do management of a ruptured cerebral aneurysm? How will you manage a patient with a ruptured cerebral aneurysm? So if you have a cerebral aneurysm which has ruptured, I need to prevent rebleed, and I will prevent the rebleed by endovascular coiling. Endovascular coiling will be the answer. Are you clear, beta? To prevent rebleed in a aneurysm, you will do endovascular coiling. Another question, anyone? Okay, beta, let's see if you can answer. What is the screening investigation to be done for a patient with ADPKD brain? What screening investigation will you use to see the brain pathology in a patient with ADPKD? This paper is available in your eMedicos app as a test paper. Can anybody tell me how will you screen? Anyone? Then the answer will be MR angiogram. MR angiogram. Okay, beta. Some of you are getting confused by clipping. Clipping is a neurosurgical technique. Usually, you will do clipping for aneurysms which cannot be coiled. Coiling is the main thing that you do. Clipping is used only for aneurysms which cannot be coiled because it requires craniotomy. It requires surgery. So that is why the answer here is coiling. Answer here is MR angiogram. Are you clear, beta? Okay, bacho. So this is the kind of question we expect in NEETPG. Short STEM clinical vignette with an image, and we need to know about the other choices. Let me ask you one more choice here. If you are thinking of extradural hemorrhage, anyone? If you are thinking of extradural hemorrhage, any one of you can answer, beta. Okay, any one of you can answer. If you are thinking of EDH, what will be the clinical symptom written in the question? Lucid interval after high speed head injury, motor vehicle accident. After head injury, lucid interval will be written, and it is usually due to rupture of middle meningeal artery. Treatment, shape will be biconvex. Treatment, craniotomy with evacuation of hematoma. An extradural hemorrhage should be urgently treated by surgery, by craniotomy, by burr hole to prevent herniation. Otherwise, the herniation will happen. So I hope this gives you the concept that we need to get into the questions. And some बच्चा is saying, sir, aneurysm rupture हो गया, अब क्या करना है? भाई देखो, whenever the aneurysm ruptures, initially it is a sentinel event. In the first few hours, there is a high likelihood of rebleed, which turns out to be a fatal event. That is why you need to manage an aneurysm with endovascular coiling. Even if it has ruptured, you need to coil it to prevent rebleed. Okay, beta. Next question. Again, NEETPG style question. All of you I want you to see what is the style of the question. Short stem of clinical vignette with a image. Are you able to see? There is an image, there is a clinical stem question. This is the style that they are following in NEETPG nowadays. Okay, any one of you can see what is the structure? Ascending aorta. Let me label it for you. Descending aorta, pulmonary artery, and we are able to appreciate a tumor. We are able to appreciate a tumor. Can you see this? Okay, this tumor is in the anterior mediastinum. It is anterior to the great vessels. It is in the anterior mediastinum. Can you tell me some examples of anterior mediastinal tumors? In the anterior mediastinum, we can have a thymoma, teratoma, thyroid, retrosternal thyroid. So, teratoma, thymoma, thyroid. But my question to you is it having fat, calcium or tooth? Fat, calcium, tooth, hair? No. It looks like a solid tumor. There is no fat inside, there is no calcium. It is not a teratoma. We now go to the clinical vignette. The question is saying patient has ptosis, muscle weakness. Maybe they are trying to give me myasthenia in the question. So my question to you is, a patient with a clinical vignette having myasthenia with the anterior mediastinal mass has to be a thymoma. Why not teratoma? Teratoma should have fat and calcium. Why not thyroid? Thyroid will be, again the retrosternal thyroid will be, because of the iodine content, thyroid is radiodense. Because of the iodine, thyroid is radiodense. Okay. What about Pankos tumor? What about Pankos tumor? Anyone? Pankos tumor should be seen in the lung apex. Can lead to Horner syndrome due to involvement of sympathetic chain. Investigation of choice, MRI. So Pankos tumor will be a lung apex tumor, which will cause invasion of the brachial plexus, invasion of your sympathetic chain, leading to Horner syndrome, leading to ptosis, and the answer, investigation of choice, will be MRI. Okay. Anyone? What about adenocancer? Adenocarcinoma are peripheral lung cancers. Small cell cancer of the lung, central cancer with paraneoplastic syndromes. So small cell cancer can have paraneoplastic syndromes like Lambert-Eaton syndrome. But what is the critical question that they ask in small cell cancer is cerebral metastasis. Anyone? Can you tell me now which lung cancer is notorious for cerebral metastasis? Which lung cancer is notorious for cerebral metastasis? Small cell cancer. Okay. So I hope this gives you the idea around the question. These are the kind of questions which is very important from the NEETPG perspective. These are called as integrated MCQs. Integrated MCQs. Okay. So because you can solve them by knowledge of your pathology, knowledge of radiology, knowledge of medicine, you can add them together and get it to the answer. Okay. So one of the things I want you to answer is, I want you to notice here is, okay beta, all of you see. Suppose you don't know radiology, it is okay. But can you connect the dot from your knowledge of pathology and get a answer, a better guess? This is what the toppers are doing. Toppers are not using a single subject to answer the questions. They are trying to play along. कि ठीक है यार, रेडियोलॉजी नहीं पता चल रहा, क्या पैथोलॉजी में ऐसा कुछ बताया था, मेडिसिन में बताया था, can I connect the dots somehow and get to the answer? That's the key that the toppers are following. Okay. And this is the challenge that NBE would have probably on Monday, by the time they get the Supreme Court notice that the paper has to be done in one set, because they might have made two sets. Now they have to converge it into one set and book more centers to do it. That is the only logistics that they need to think about. It can be done fast. They can do the exam on the same date, but we know that sometimes the government machinery, they might take time on, but only thing that is required is you have to merge those two sets into one, book some more centers to do the paper, like we do in DAM CBT. Okay, we are doing our CBT tomorrow as well. Okay, bacho, let's see. And so all over India, we are booking centers to do your CBT, and many of you would be attending it with us. So I am always proud to say that despite being a private organization, we work very hard. We work day in, day out to make sure that we give you the same experience that you get in the real exams. Okay. Okay, beta. Next question. Patient has dull aching pain. Dull aching pain. Why would somebody have pain? Maybe some inflammatory problem is going on with pus cells in the urine. Pus cells in the urine indicate UTI, urinary tract infection. But then why are the cultures sterile? It could be some other than routine infection. Other than routine. Routine infection is E. coli. So this is not E. coli. Look at the X-ray. X-ray is showing me. calcification of the kidney. Right side kidney is calcified, clear, contracted. That means there is a chronic inflammatory process with dystrophic calcification happening. But why is the bladder not calcified? That means the disease started in the kidney and has gone to the bladder. That means it is a hematogenous infection of the kidney called as tuberculosis of the kidney, also called as putty kidney. Okay, let me ask you some questions now. Sir, why it is not a calcified Schwarz abscess? So let me show you Schwarz on the X-ray. This is the Schwarz outline, beta. This is the Schwarz outline. Are you able to see this? This is the Schwarz outline. So if you see this, if there is a Schwarz calcification, that calcium should be here. Okay, are you clear? Which is the possible question in the exam. They might show you later on in the exam Schwarz calcification after tuberculosis with Schwarz abscess, but you need to look at Schwarz calcification in the area of the spine. Adjoining the spine, you can see the Schwarz shadow. Okay, why the answer is not nephrocalcinosis? Nephrocalcinosis is usually bilateral, seen in patients with hyperparathyroidism. Why not? Why hyperparathyroidism? Because of hypercalcemia. If you have more calcium will be excreted and the renal medulla will get calcified. And this is definitely not taking the shape of the staghorn calculus. It is not a staghorn calculus. Whenever they show you staghorn calculus in NEETPG, everybody remember, they will talk about Proteus infection. Okay, bacho? They will talk about a constitution of staghorn calculus. Staghorn calculus in patients with Proteus infection are made up of. Can anybody answer? Are made up of? Can you tell me? Staghorn calculus in patients with Proteus infection will be made up of struvite. The answer will be struvite, triple phosphate. The answer will be struvite or triple phosphate. One more question that I am expecting on similar lines is, any one of you can answer, beta. Any one of you can answer, beta. What is the investigation of choice for ureteric stone? Patient is having a colicky pain, you are suspecting ureteric stone. What is the best thing that you can do for him? You can do a NCCT. This is what you saw in the NESET paper. Okay, if you have a ureteric stone, ureteric colic, you need to do a NCCT. That is the single best investigation to be done in that case. Okay, so we discussed the 3 questions so far. All of them are NEETPG style, NEETPG favorite topics, image based questions with a short clinical history, beta. Okay, beta. 4th topic is they might ask you a bone tumor. Okay, so again you will see a stem and a image. I will start with the choices first. At what age group will you see a GCT? At what age group will you see giant cell tumor? Anyone? GCT is seen in adults. Location: epiphysis, expansile lesion just below the joint, soap bubble appearance. Where will you see chondroblastoma? Chondroblastoma is seen in children in the epiphysis of a child. Okay, beta. What about osteochondroma? Osteochondroma will be seen as a bony stalk pointing away from the joint. Aneurysmal bone cyst will be seen in the metaphysis of a child as a expansile lesion. Okay. Now I want you all to look at the X-ray and tell me the age. What is the age of the patient? This is a adult. Sir, how do you know? The growth plates have fused. Where is the disease? In the epiphysis, in the subarticular area, there is a expansile soap bubble lesion in the ulna. Okay, so this is not a child, this is an adult. It cannot be chondroblastoma. It is not an aneurysmal bone cyst. It is not a bony stalk. What is the best answer? GCT. This is called as method of elimination. What I have learned is, whenever you are appearing for a multiple choice question, you may or may not know the answer, but you should know what are not the answers. You need to eliminate. Once you start eliminating, you improve your probability of getting the question right. You improve your probability, okay? And we need to know that usually the end of the bone will be taken as the epiphysis in the adult, but this is an adult X-ray, which is the very critical thing which is solving the problem for you. Okay, are you clear? Okay, bacho. Let's see the next question. Okay, so if you notice, I have given you the idea behind how to get to the answer. Now I will start predicting. One of my predictions is that esophagus is a very important topic for NEETPG. Sometimes they show, like I give you some questions that they have asked already. Sometimes they will show you achalasia. Sometimes they will show you CA esophagus. Sometimes they will show diffuse esophageal spasm. Sometimes they will show you Zenker's diverticulum. These are the previous questions that have been asked. Achalasia, CA esophagus, diffuse esophageal spasm, the corkscrew appearance, and Zenker's. Now my feeling is they will change the question now to this investigation. This is an investigation showing me endoscopic ultrasound. This is the endoscopic ultrasound. And why do you do endoscopic ultrasound in? Can you tell me why do you do endoscopic ultrasound for esophagus? You do it for staging. You do it for T staging, local staging of CA esophagus. Okay, so keep it in mind, in CA esophagus, distant metastasis needs a PET CT evaluation. CA stomach, CA esophagus, PET CT for distant metastasis. Okay, for local staging, T staging, we use a endoscopic ultrasound, which is what we see here, and this is a possible NEETPG question now. The reason I'm saying is because they have asked achalasia, CA esophagus, DEC on barium images. So my prediction is कि बॉस बेरियम हो गया, अभी जो असली में करते हैं वो पूछना पड़ेगा ना. Now for staging we use endoscopic ultrasound. So this is a very important question. And what will you get confused? Sir, why not GRD? GRD requires a 24-hour pH monitoring. Okay. Why not heart and aorta? For heart and aortic conditions, we use transesophageal echocardiography. Okay, we use transesophageal echocardiography. So in that you should see the heart. So some of you might have said, sir, ये heart के लिए क्यों नहीं हो रहा? Heart दिख ही नहीं रहा. If it was a transesophageal echocardiogram, you should see the cardiac chambers, which is not visible here. Okay, so that helps us to get to the answer. Okay, let's do another question. Again, last year's NEETPG style. Patient has a known case of CSOM, has seizures, headache, vomiting, photophobia, and you see what is the CT scan showing us? This is a contrast enhanced CT scan of the brain, which is showing me a ring enhancing lesion in the temporal lobe of the brain. There is a ring enhancing lesion. So where it is located, let me help you. This is your frontal lobe. This is your temporal lobe. Okay, and this is your cerebellum. Are you able to see the anatomy? Okay, so we can definitely see it is in the middle cranial fossa, a ring lesion. Why would you have ring lesion in a patient with a reservoir of infection like ear infection? That means it is a abscess. That means it is a brain abscess. And this is the style I am predicting for your NEETPG paper. Last year NEETPG they said, can you tell me which ring lesion will be bright on diffusion weighted MRI? Which ring lesion will be bright on diffusion weighted MRI? Anyone? Abscess. Abscess will be bright on diffusion weighted MRI. Okay, beta, one more question. Which ring lesion will have a dot or a scolex inside? Which ring lesion? Inside the ring you will see a dot like a scolex. Anyone? Then the answer will be neurocysticercosis. Then the answer will be neurocysticercosis. Okay बच्चों. Which ring lesion is most commonly seen in patients who are HIV positive? Which ring lesion will you see in patients who are HIV positive? Any one of you can answer. Bolo, 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 bolo. The answer will be, tell me, the answer will be toxoplasmosis. Most common ring lesion in HIV patients will be toxoplasmosis. Are you able to do it now? Okay. So, others are also possible. Some of you are saying TB. That is also possible. Most commonly, toxoplasma will be the cause. Okay, beta? Yes. So, what we have done here is, over a period of few questions, we have looked at the pattern of the real exam. I am guaranteeing you this is how the real NEETPG feels like. Are you able to do it? Okay, beta. Okay. Now, let's predict a question on gynae. They like integration between subjects. Integration can be between clinical and clinical subject, clinical and basic sciences. So, suppose they say you want to assess fetal anemia. What test will you do? You will do a Doppler. What Doppler finding will tell you there is fetal anemia? If there is increase in the peak systolic velocity in the fetal middle cerebral artery. That means if because of the brain sparing, if there is anemia, there will be hyperdynamic circulation in the fetus, which will be seen in the cerebral circulation, and the fetal MCA, peak systolic velocity, which can be written as PSV, will be high. Peak systolic velocity will be high. So this is a Doppler question on gynae. Let me ask you few questions which I can predict on the same topic. Let's see if you can answer beta. Any one of you can try and answer beta. What is the most ominous sign in umbilical artery Doppler? When we do it in IUGR, what is the most ominous sign in umbilical artery Doppler? A previous NEETPG question coming your way. Let's see how many of you can answer. So, most ominous sign on umbilical artery Doppler is reversal of the end diastolic flow, which indicates impending IUD, which indicates impending IUD. Very good. I have never seen more intelligent students in any of my class. Let's see if you can answer this one. अब तो मुश्किल करना पड़ेगा, आप बताते हैं. देखो, if you see persistent diastolic notch in the uterine artery after 22 weeks, what does this predict? If you see persistent diastolic notch in the uterine artery even after 22 weeks, then anyone? Then the answer will be, tell me, predictor for preeclampsia. So you might see same question you will find in an obs and gynae discussion and radiology, because भाई fetus उनका है लेकिन Doppler तो हमारा है. So that is called as integration. So you will see that this is the pan that the examiners are using. They try to put questions which are integrated, where you can answer it from your radiology knowledge or from your obs and gynae knowledge. दोनों में से एक knowledge से आप कर सकते हो. Can you do it? समझ पा रहे हैं? Okay बेटा. So this helps you to get that advantage in the real exam. Real exam is easier. घबराने की कोई बात नहीं. Okay. The only thing I wanted to tell you today is, because by chance my class is coinciding with the Supreme Court verdict that has come recently. So my duty is to tell you that exam will happen. पक्का एग्जाम तो होगा ही होगा. डू यू एग्री कि नहीं? थोड़ा हो सकता है कि वो पैटर्न बदलें, डेट बदलें, जो भी वो चाहते हैं वो करेंगे, लेकिन होगा तो सही. टेल मी, होगा तो सही. यस. तो पढ़ता तो रहे भाई, पढ़ाई मत छोड़, पढ़ता तो रहे. ठीक है ना? सो डोंट मिस आउट ऑन योर टेस्ट एंड पेपर. कीप द मोमेंटम गोइंग. एग्जाम विल हैपन. एग्जाम विल हैपन. ओके. नेक्स्ट प्रेडिक्टर. दे लाइक आस्किंग पेट स्कैन. दे लाइक आस्किंग पेट स्कैन. गैलियम PSMA can be used for. So what is PSMA? PSMA is prostate specific membrane antigen. Prostate specific membrane antigen. Okay, what is gallium? Gallium is gallium-68. It is a non-cyclotron PET isotope. The commonly used isotope in PET scan is FDG. To produce FDG, we need cyclotron. Gallium-68 is a non-cyclotron PET isotope. Okay, so gallium with PSMA, which is prostate specific membrane antigen, is used for prostate cancer. Prostate cancer. Now I will ask you a very difficult question now. Let's see if you can answer. Why would you use actinium PSMA? Okay, tell me. So gallium PSMA is used to see prostate cancer on a PET scan. Okay, अब ये बताना बेटा आपने, actinium PSMA is going to be used for. Actinium is a alpha emitter. So this is a targeted alpha therapy for prostate cancer. Targeted alpha therapy for prostate cancer. New update, has never been asked. समझ पा रहे हैं? गैलियम पीएसएमए डेफिनेटली पॉसिबल क्वेश्चन. डायग्नोसिस, इसका पर्पस है देखना कैंसर को, इसका पर्पस है ट्रीटमेंट करना. सो एक्टिनियम पीएसएमए थेरेपी इज अ टारगेटेड अल्फा थेरेपी. याद कर लो, वर्ड पेपर में लिखा होगा अल्फा थेरेपी. ओके, एंड आई होप यू रिमेंबर अल्फा मीन्स द फर्स्ट इन द गेम, फर्स्ट इन द गेम, एंड NEETPG अल्फा ओनली डैम्स. Do you remember this? याद करके रखना बेटा. Okay, so we are the ones who started this and we are here to tell you, boss, पढ़ते रहो, पढ़ते रहो, पढ़ते रहो. हम साथ हैं बेटा, पढ़ेंगे. हम इतना मोमेंटम को बिल्ड करेंगे कि आप लगे रहोगे बेटा. ठीक है? ओके, बायरार्ड्स, ब्रेस्ट इमेजिंग, टॉपिक मैमोग्राफी, कैटेगरी 3. कैटेगरी 3. ओके बेटा, एनीवन? कैटेगरी 0 is inadequate for opinion. 1 negative. Okay beta. 2. Okay, anyone can tell me what is Bayard's category 2? Bayard's category 2 is benign. 3 is probably benign. 4 suspicious for cancer. 5 suggestive of cancer. 6 known case of biopsy proven cancer. Okay, my question to you is, how will you manage Bayard's 3? Bayard's 3 means there is less than 2% likelihood of cancer. Management will be short term 6-month follow up. Management will be short term 6-month follow up, and it is less than 2% chances of cancer. Okay, when we say Bayard 5, it is more than 95% likelihood of cancer. Breast cancer or mammography is a very important question in our exams. So let me ask you a question. What are the 2 views that we do in a mammogram? Name the 2 X-ray projections that you do in a mammogram. Anyone? We do CCMLO. CCMLO. And the maximum breast tissue is seen by, maximum breast tissue is seen by MLO. Maximum breast tissue seen by MLO. Okay beta, 2 questions for you. What is the most important sign? What is the most important mammography sign of ductal carcinoma in situ breast? Okay beta, what is the most important sign of ductal carcinoma in situ breast on mammogram? Can anybody tell me? Microcalcification. Microcalcification. Okay, and what is the investigation of choice for breast implants? Previous NEETPG question. What is the investigation of choice for breast implants? The answer is MRI. The answer is MRI. Okay. So next is a possible question in the exam. In NEETPG, they like to use the word identify. Identify either the anatomy on the image or identify the investigation. So let me label the anatomy for you. This is a CT scan of the brain done at the level of basal ganglia, and I want you to see this is your lateral ventricle, third ventricle. The slit like space that you see in the center is your third ventricle. Touching the lateral ventricle, you have the head of the caudate nucleus. Touching the third ventricle, we have the thalami, and then behind the caudate you have the lentiform nucleus. Between caudate, lentiform and thalamus, you have the internal capsule. So where are the arrows? So we know the arrow is at a structure which is touching the third ventricle. That means the arrows are at the thalami. You are able to identify the thalamus. It is not at the internal capsule, it is not at the caudate, not at the other basal ganglia. The answer is thalamus, which is your sensory relay organ. So the theme is either identify the anatomy, or they will give you a question saying identify the investigation. They will give you the question identify the investigation. Are you able to do it, beta? Okay. Okay. So let's do some science. Now, one of the things I have observed is that in this year's NEETPG, so in this year's NEETPG as well as INISET paper, if you remember INISET, they are going for some vague signs. I'll give you some examples of named signs that have been asked in this INISET paper. Anyone remembers? Eye of the tiger sign, INISET May 2025 CNN, pentothenate kinase associated neurodegeneration. Honda sign, sacral insufficiency fracture. So going by the theme that they are asking signs, I am going to show you a sign called as double PCL sign. I will help you. Let us try to understand the anatomy in this question. This is femur, tibia, patella. Between femur and your tibia, are you able to see this? Yes, this is your posterior cruciate ligament. This is your posterior cruciate ligament. But sir, there are two such things. You cannot have two PCL. So why is the double PCL visible? Double PCL is visible because there is a bucket handle tear of the medial meniscus, and the torn fragment of the meniscus is forming the second PCL. So it is nothing but a bucket handle tear of the medial meniscus, which is looking like a double PCL. So double PCL is a rare sign they ask in the exam, but they can ask you. So then the answer will be medial meniscal tear. It is not a PCL tear, it is a medial meniscus tear. Another vague name that they have asked in INISET recently was Mount Fuji sign. Anybody remembers Mount Fuji sign seen in tension, pneumocephalus? So in INISET and NEETPG there is a difference. NEETPG they like short stem clinical questions. INISET they like one-liners, image one-liners to identify. Like two one-liners have been asked this year. In your INISET paper. Two one-liners they have asked. Remember, eye of the tiger, Honda sign. Last time they have asked Mount Fuji sign. So keep this in mind. Keep this in mind, beta. Okay. This patient, another of the favorite question of NEETPG is pneumo. Patient has a acute abdominal pain. X-ray abdomen is shown to you. What do you see? There is gas below the right diaphragm. Why do you have gas below the right diaphragm? This is pneumoperitoneum. Why do you have pneumoperitoneum? This must be a hollow viscous perforation. If there is a hollow viscous perforation, my dear children, how will you manage? So perforation requires, tell me, laparotomy. So you need to do a exploratory laparotomy after initial resuscitation. You will have to do a laparotomy. Okay, are you able to do it? Okay, beta. Another such question. Patient has a history of road traffic accident. CT scan is shown to you. What do you see here? Hemorrhage. You can see a hemorrhage. What is the shape of the hemorrhage? Biconvex. Limited by sutures. Limited by sutures. Due to rupture of middle meningeal artery. Due to rupture of middle meningeal artery. Which hemorrhage? Extradural hemorrhage. EDH. Patient can have lucid interval. Patient can show lucid interval. Now my question is, it is most commonly caused from bleeding from middle meningeal artery. Bridging veins is the most common source for subdural hemorrhage. Berry aneurysm rupture is a source of SAH. Middle meningeal artery is a source of EDH. Can any of you tell me what will be the history in subdural hemorrhage? In the subdural hemorrhage, they will always say this is an old patient with history of minor fall in the bathroom. The shape of the hemorrhage will be concavo-convex. Okay, so old patient with minor injury, think of concavo-convex subdural hemorrhage, which is due to rupture of bridging vein. Elderly will be the keyword in the question. How will you manage EDH? What will be the management? Urgent surgical to prevent herniation. Okay, bacho. Next, I am giving you a question to solve, and I just want you to look at this question history, and you will see some questions I have tried to keep the PYQ, some I have tried to make it a little tough, so that you are clear on the real paper. This is 1 week history of low grade fever, chest pain, chest X-ray shown to you. Look at the X-ray and tell me what is the most critical finding that you can see on this X-ray. What is the most critical finding? The most critical finding on the X-ray is cardiomegaly. The heart size is enlarged. But my question to you is this patient in heart failure or not? Do you think he has heart failure? No. Why not? Because although there is cardiomegaly, if I look at the lungs are clear. Paradoxically, there is a large heart, but the lungs are totally clear. Why are the lungs clear? And is it only a right ventricular enlargement, right atrial enlargement, or the entire heart, entire cardiac silhouette is enlarged like a water bottle, like a money bag? So there is no single chamber enlargement. It is a very money bag like enlargement. We have to think of pericardial effusion as the answer. Okay, why not pneumonia? Pneumonia will be an opacity with air bronchogram. Lung should have an opacity with air bronchogram. What is the X-ray feature of coarctation of aorta? Anyone? Figure of 3 appearance of aorta, coarctation. Anybody else? Any one of you can tell me, beta, coarctation of aorta में ribs को क्या होगा? Ribs को क्या होगा? Ribs. There will be inferior rib notching. Inferior rib notching involving the 3rd to 8th ribs. How will you diagnose aortic dissection? Aortic dissection in a stable patient will be diagnosed on a CT angiogram. Aortic dissection will not be diagnosed on a X-ray, it will be diagnosed on a CT angiogram in a stable patient. And you will see a double lumen aorta, and you have to see the classifications. Remember, these classification are Stanford classification and DeBakey classification. Aortic dissection, the classifications that we use are Stanford, which is more commonly used clinically, and the DeBakey classification. If the patient is unstable and you're thinking of dissection, if the patient is unstable, you will confirm your diagnosis on a transesophageal echocardiogram. If the patient is unstable, you will use a transesophageal echocardiogram. And with this, we come to the final question of this test paper. Okay, so I've tried to give you a mix and match of clinical spots and vignettes. I've tried to give you the feel of the NEETPG. Sometimes they give you 15 questions in NEETPG with images. They are not actually radiology. They are integrated radiology with other systems. This is a newborn abdominal distension, barium enema. What do you see? There is some normal caliber of the colon, then there is dilated, there is an abrupt change in caliber. Do you notice that? There is a change in caliber. Suddenly there is a dilated colon, newborn, you see a normal caliber, a sudden change in caliber because of a ganglionic segment which is known to happen in Hirschsprung's disease. This is a patient with Hirschsprung's disease. This is not toxic megacolon, this is congenital megacolon. Toxic megacolon will be a known case of ulcerative colitis. Presents to emergency with more than 6 centimeter diameter of transverse colon. Okay. Meconium ileus will be soap bubble like appearance in right iliac fossa with no air fluid levels. Meconium ileus will be a cystic fibrosis newborn with soap bubble appearance in the right iliac fossa, no air fluid levels, and a gastrographin enema will be both therapeutic and diagnostic. Gastrographic enema will be both therapeutic and, remember, and diagnostic. Some of you are saying, why not anal atresia? Because you can see the barium is going till the end. So there is no anal atresia. Usually when they say anorectal malformation, they might show you an inverted invertogram where you put a coin at the anal pit and the air is not reaching till the coin to diagnose that anorectal malformation in the question. Okay, so this is a clear barium enema, and you have given the barium per rectal and it is gone. You see an abrupt change in caliber which helps you to make a diagnosis. Toxic megacolon, the history should say inflammatory bowel disease. It should be a history of known case of inflammatory bowel disease with a acute exasperation and a dilated colon. Okay, so I hope this helps you with the integrated approach for the exams. All I can tell you in the end today is, and which is very important, and you know, it is the time that we are in. There is a time that we need to learn which is called as uncertainty. Uncertainty means that till yesterday we were very certain that the exam is happening on time. Now we know that the Supreme Court has decided that the exam will happen in one shift, which is actually an excellent decision. Which is a very excellent decision, because once the paper happens in single shift, it removes all the ambiguities of statistics that comes in our way. Statistics, mostly the PSM people are able to understand. Normal people, we can't understand what they are saying, normalization and all those things. So for us, I believe single shift paper should be the way forward. Single shift paper should always be done. That is the how it goes. The only challenges now are uncertainty means exam date, when will they, and any centers, and when will they allocate. Now, so they have to make a single shift paper and they have to do. If so, my only suggestion is that there are things beyond our control. So we do not know what will happen by Monday. They will come back and decide, and we don't know what will they decide. But paper तो होगा ही होगा, पढ़ना तो चालू रख. 2 दिन तेरे वेट करने से कुछ बदलेगा तो नहीं ना. So paper तो होगा ही होगा. So all my life, this is the principle I use. Focus on what you can control. Focus on what you can control. है ना. अभी ऐसा थोड़ी ना कि कल को कोविड पैंडेमिक आ जाता है, कुछ आ जाता है. So it's not everything is in your hand as a child. You need to know what is in your hand and then focus on it. Your hand is study, and your DVT live rapid revision should be your continuous resources for revision. This is what you need to keep doing and keep practicing your grand test. I wish you all the best for tomorrow's CBT. CBT जरूर दे के आना है। और आखिर में एक ही चीज बतानी है बेटा कि चाहे कुछ भी हो जाए, चाहे कुछ भी हो जाए, अपना टाइम कौन लाएगा? चाहे कुछ भी हो जाए, अपना टाइम कौन लाएगा? बोल भाई बोल, अपना टाइम अपन खुद लाएगा, खुद लाएगा। We'll keep continuing to support you through our various endeavors and ideas. We'll keep doing the Predictor Series and marathon as per schedules, but we will look at everything that comes our way. We will be with you in the journey. We'll keep telling you, boss, अभी ऐसा हो गया तो ऐसा कर लेते हैं, ऐसा हो गया तो ऐसा कर लेते हैं, हम साथ रहेंगे. We wish you all the best. Keep rocking and do subscribe to the channel so that you don't miss out on important videos on this educational channel. Please click on the subscribe button. कहीं ऐसा ना हो हम कोई वीडियो लाइव कर रहे हैं आप मिस कर दें. Wish you all the best बेटा. Keep rocking. Keep reminding yourself अपना टाइम आएगा नहीं, अपन खुद लाएगा.